Okay, we're looking at the physiology of the respiratory system in this lecture, and we're going to begin with a discussion of what's known as pulmonary ventilation. Ventilation refers strictly just to how it is air can get into and out of the lungs in the first place. What are the mechanics that drive it? It relies on this principle known as Boyle's law, which basically states that in any closed container, the pressure is going to be inversely proportional to the volume. So inversely means whatever you do to the one, the opposite is done to the other. So, for example, if I increased the volume, it would lead to a decrease in the pressure inside the container. Or if I decreased the volume of the container, it would lead to an increase in the pressure. And this has everything to do with how often on a microscopic level, it has everything to do with how often the gas molecules collide with one another. So here's an illustration from the book showing two different containers, one larger, one bigger. And in the larger container, you have all these gas molecules, and because there's more room for them to run, there's fewer collisions on average, and because there are fewer collisions, ultimately that leads to a lesser pressure. Now, if you were to plunge the piston down, same amount of gas, but now it's occupying, let's say, half the volume. For any equivalent distance traveled, the particles would bounce into the wall and collide with each other more frequently. So they would result in a greater pressure. Pressure is really determined ultimately by how frequently and often gas molecules are bumping into one another. So all that to say, you shrink the volume, you increase the pressure. You increase the volume, you decrease the pressure for any relatively closed container. And we see that happening in the lungs. So what happens is that there is your lung tissue, and the underlying feature that makes this all happen is what's known as the pleural membrane. One of the tricky parts is about having all of that elasticity wrapping around the alveoli of your lungs. It's perpetually pulling the lungs down. The lungs want to retract because they are under that tension, and it's a good and beautiful thing. It makes it so that your expiration is passive. But you have to find some way to keep the lungs from deflating and collapsing. And so the way that it's done is there's a membrane called the pleural membrane that wraps around the lungs. It's a serosal membrane, so it means it's similar to the pericardium in the heart. A serosal membrane, recall, is best, I think, illustrated by punching a water balloon. And this is the illustration the book uses. So if you had a water balloon like this and you punched it, here's your fist. Okay, really horrible drawing of a fist, but all to illustrate, if you did that, there would be two membranes, one that's closest to your fist and then the outer one, and then there'd be water in between. Okay, that's a serosal membrane, and you find them in different compartments of the body. The thoracic compartment is no exception. So here we have a membrane closely associated with the lobes of the lung. That's called the visceral pleura. You also have then that same membrane, but now traveling around the outer wall against the wall of your thoracic cavity, so that would be the parietal pleura, and then there's fluid that's in between those. Well, what the fluid does is it makes the lungs attach to the wall of the thoracic cavity. There's only so much fluid in here, and so the elasticity of the lungs will start to pull, but it can only get so far because of the fact that it creates a vacuum in this space, and the forces of elasticity are not great enough to overcome that vacuum, which is created, which is about a -4 millimeters mercury pressure here. And so the lungs will recoil a little bit, but it can't ever get much beyond that because it takes a significant amount of force to overcome the forces of a vacuum that are created. And if you don't understand, they're showing you all the different types of pressures here. You don't necessarily need to know what all of those are, but in essence, you just have to understand the fact that this is stuck to this because there's fluid in between those, keeping them anchored together. And what can happen like for a variety of reasons. One could be that there's an injury and there's actually a wound, let's say a stab wound or a laceration that opens this cavity up. If air gets in here and seeps through, or if there's they're called blebs, when air escapes out of the lungs and gets into this space, it's a condition known as pneumothorax. And if bubbles get in here, it's going to disrupt the seal, and it could be that your lung actually pulls back and collapses. So that's just to illustrate how important it is to have this continuous fluid inside there. It keeps the walls of the lungs, despite the fact that they want to recoil, it keeps them anchored close to the walls of the thorax. And if we can accomplish that, then if we can change the volume of the thoracic cavity, the lungs, though under tension and wanting to recoil, the lungs will follow suit and follow along. And that's what's going to allow us to change the pressure, specifically of the intraalveolar pressure. It's going to change the pressure inside of the alveoli. Okay, this is illustrating what would happen under a condition known as pneumothorax, where the wall retracts off of the walls of the thorax. This would happen again because air seeped through and disrupted the seal. Air escaped the alveoli, or maybe there was a trauma wound and air from the outside got into the thoracic cavity. Either one would make the lungs collapse. And that's not to be confused with another condition known as atelectasis, and that would be a condition where there is some collapsing of the alveoli, but it's generally not because there's air in between this seal. It's because there's like something that's plugged up, or the individual alveoli have collapsed because of a change in pressure that results. So a little bit different conditions there. All right, so here's anatomically what's going on to change the volume of your thoracic cavity. Much of it has to do with your diaphragm. So your diaphragm sits in this C-shaped curved state here. Your diaphragm, if you were to unfurl it and look at it, there's what's known as a central tendon, which is not really much muscle here, and then there's a bunch of muscle that wraps around it. And so when the muscle contracts, think about it almost like what I'm thinking of in my mind here is like, I remember as a kid going to the gym and they had like these parachute things, and if you could bounce balls in the parachute, but if everybody pulled on the bands of the parachute, it would tighten the parachute and make it really taut. That's sort of what's happening here in the muscle. When the muscle ring of muscle contracts, it pulls tight the diaphragm. So I guess let's go back up here. This is more of the shape of what it looks like in a relaxed state. And if you contract the ring of muscle, it pulls this parachute tight, and it will look something more like this. Okay, and when it's relaxed, it goes back, and then when you pull it tight, it moves forward. So the diaphragm is constantly moving in and out, in and out, in and out. When you contract it, it flings forward. When you relax it, it comes back to its resting state. When you contract it, it moves forward. When you relax it, it goes back to its resting state. It's like a little bell. And when it does contract and the ring is pulled taut and that forces the diaphragm outward, you can see it's going to be a pretty big expansion in the volume of the thoracic cavity. Like imagine I was to superimpose the relaxed state here. This is about where the diaphragm was in the relaxed state. We've regained all of this volume here when it contracts. So you're increasing the volume of the thoracic cavity at the end of the day. This is predominantly accomplished by the diaphragm, but there are some other muscles involved here, like the external intercostal muscles. When they contract, they elevate the ribs, and that pushes the ribs out a little bit. So between pushing the floor out with the diaphragm and lifting the ribs up, two ways there to expand the chest. And then to decrease the size of the chest, the muscle of the diaphragm would relax, and now the internal intercostals take place. The external ones will relax, and the internal ones can contract to actually pull those ribs back down and shrink the wall of the chest. And then coupled with Boyle's law, when you expand the volume, what does it do to the pressure? $1,000,000 question. It decreases the pressure. And if you decrease the pressure in here, there's now a differential. There's a gradient of pressures between the outside environment and the inside environment. You have momentarily made this more negative, and this was more positive, and now you have a difference in the pressure, and air would always travel from high pressure to low pressure. And if you can create that gradient, it will allow the air to follow, and that's why you breathe in. Similarly, let's imagine you've just finished your inspiration, and now your diaphragm is relaxing, so it's recoiling back into this bell-shaped position, and the ribs are depressing. Well, now you're shrinking the volume, and according to Boyle's law, if you decrease the volume of the container, it will lead to actually an increase in the pressure, because again, the molecules of air are hitting each other more rapidly. And now you actually have a reverse gradient. You have the pressure higher here and less outside, so that's going to push air out. So on the exam, I can ask you questions like this. I can ask you, for inspiration, would it result from increasing the volume of the thoracic cavity or decreasing the wall of the thoracic cavity? And you would want to say inspiration is the result of increasing the wall of the thoracic cavity. Or I could ask, is inspiration result from increasing or decreasing the pressure inside the thoracic cavity? And you'd say that inspiration results when you decrease the pressure, because now you have a vacuum that draws the air in. Okay, if you were to chart this then, and you were measuring specifically the pressure differential, so the difference between the atmospheric pressure, the air in the pressure in the room versus the pressure inside your alveoli, this would be the difference. And it's a very subtle difference. It doesn't take much of a gradient to get the air to start flowing. We only max out at about a gradient of 1 millimeter of mercury, and that's all the gradient that's required. That's all the differential that's required to start breathing, having air flow in and out. So what happens is when you contract your diaphragm and your external intercostals, and you raise the rib cage and you push out the floor of the thoracic wall, you're creating a vacuum. And so as the wall expands, the vacuum becomes greater, and the differential, and so then consequently air is starting to flow in. This would be your tidal volume here, so the air inside your lungs. And then at max differential, when the muscles are contracted fully and the air is still trying to catch up, you'll see there's an inflection point, and the air will increase its velocity that it comes in. And then we're still negative, still negative, still negative, and then at the point that we're about ready to breathe out now we're starting to get a positive slope here on the differential, and that's going to start leading to air escaping. And then as the muscles contract, there's going to be a maximum pressure differential where there's air that's bottled up that needs to get out, and the difference is 1 millimeter of mercury inside versus the atmospheric air. And so that's when the air is really going to jump out, and then it tapers off. Okay, so all has to do with the difference in pressure between inside of the lungs and the atmosphere, the air that you're inspiring or exhaling. All right, now some of the ways that we can measure the volumes that you're breathing. This is known as spirometry, and you could make something that's called a spirograph, which would look something like this. And there are different volumes of capacities that we can measure when we're assessing one's pulmonary function, and they are the following. If you're just breathing in and out, just a normal steady breathing, this is called the tidal volume, or the TV. And it's about 500 millimeters of mercury, half a liter, or sorry, not millimeters of mercury, 500 milliliters, about a half of a liter of air goes in and out of your lungs every time you breathe. That will change depending on how tall you are and whether you're male or female, but roughly it's about a half of a liter. If you were to breathe out a normal breath and then breathe out as much as you possibly could, that total amount that's on reserve to be expired would be called the expiratory reserve volume. And it would be something to the tune of like 1.5 liters or a liter. Okay, if you were to breathe a normal amount and at the top of your breath, you breathed in as much as you possibly could, that would be called not the expiratory reserve volume, but the inspiratory reserve volume. So it's the amount you have on reserve to inhale or inspire above and beyond a normal breath. And this is one of the greatest ones. So you can actually breathe in more above a normal breath generally than you can exhale out after a normal breath. Now, if you were at the very top, let's say, of the biggest breath you could gather, and you breathed out until you could not breathe any more whatsoever at all, this would be called the vital capacity. It's the total amount of displacement you can get into and out of your lungs. The total amount you can get into and out of your lungs. Now, you're never going to be able to get rid of everything in your lungs because there's always going to be some air in the conducting portions of your airway, so like in the trachea and in the bronchi and things like that. That amount of air that remains is called the residual volume, and it's always going to stay there. You'll never be able to get it out because you can't depress down those airways. They're mostly open, and if you could get that residual volume out, but you can't. If you take the vital capacity, the total amount of air you can change or displace in your lungs of your own volition, you add to it the residual volume, the amount that's left over, you get what's known as the TLC, that stands for tender, love, and care. I'm just kidding. It stands for the total lung capacity. And that would be the total amount of air that can be inside your lungs at any maximum total amount of air that could be in your lungs at any given point in time. Now, there are a couple of different types of pulmonary disorders that can affect these volumes, and you could actually diagnose by doing making a spirogram, and you can do this oftentimes in a day clinic. They'll have a little spirometer, a little benchtop spirometer they can pull out, and you can breathe in and out of it, and they'll assess some of these volumes to figure out what type of respiratory issues you might be encountering. Regardless of what the issue is, generally they'll fall under two camps. Anything that obstructs your airway or makes it difficult to breathe, oftentimes you can categorize it into two different camps of disorders. One is called an obstructive disorder, the other one's called a restrictive disorder. And the descriptions are the following. A restrictive disorder would be any disorder where the lungs can't inflate because there's something occupying the space that the lung tissue should normally otherwise occupy. So in other words, your lungs just can't expand with as much air because there's stuff in the way. There's stuff taking up the space that inspired air would normally take. This could be because you have swelling, like edema. There's pooling of swelling happening and pooling of fluid. It could be because there's a mass, like a tumor, a mesothelioma, something like that in the way that's taking up space. So that'd be a restrictive disorder. An obstructive disorder, in contrast, would be one in which the lungs can inflate the entire way. There's nothing taking up the space, but it's more difficult to breathe because the airways are obstructed. The airways are closed off. They're more obstructed, and this could be because there's mucus coating them, oversecretion of mucus because maybe you're battling, let's say, pneumonia, and there's mucus that's being created and staying, or maybe there's chronic inflammation, and so the bronchioles are inflamed, so they're swelling up, and now the opening in the airway is narrowed. It's just more difficult to breathe. Generally, we saw this in the cardiovascular system. If you shrink a tube, right, it greatly increases the resistance. There's a lot less flow in a tube that's narrower than there is in a tube that's larger. And shrinking the tube has a huge impact on how flow passes through. Recall that if you shrink this by a half, if you half the diameter, it will actually make it 16 times more difficult for flow to pass through. So even though you're just shrinking by 50%, 16 times more difficult. And if something's 16 times more difficult to flow, that's a lot more effort. You have to exert yourself 16 times more forcefully to get air to pass through. Now, I generally think in the respiratory system you don't see that type of closing off where the diameter would be shrunk by half, but it could be the case. Well, in either case, that's the difference. Restrictive, there's something taking up space. Obstructive, something's narrowing the airway, making it more difficult for air to get in and out. But you could still expand your lungs, the total amount. It just might take more effort and time to do so. Okay, the way that you could diagnose these then is by considering some variables here. One's called the forced expiratory volume. Specifically, often we use FEV1, which would be if you're breathing out forcefully as possible, how much of your air can you get rid of in a second? Okay, and oftentimes we would compare that with what's known as the forced expiratory reserve volume 4, which would be how much air you've gotten rid of in 4 seconds. Well, generally, it doesn't take 4 seconds for you to get rid of all your air. You'll get rid of all your air. If you're breathing out forcefully and intensely, you should get rid of all of your air in like 3 seconds. So effectively then, the forced expiratory volume 4 is going to be roughly equivalent to one's vital capacity, how much air they can totally get rid of totally, all right? So we'll just use VC here, vital capacity, to clear up the number of variables we're dealing with. Well, if you know what the FEV1 is and the vital capacity, you can determine quite a bit from that. And oftentimes this is done using what's known as the FEV1 and the vital capacity ratio. So in essence, if there's a restrictive disorder, you would expect it might not necessarily affect the FEV1 all that much, but it will affect the vital capacity because remember, something's taking up the space, so there's just not as much displacement that can occur because they've got a mass or some fluid taking up room. So you would diagnose this generally if you just looked at reference values. There are certain reference values for what would be normal for an individual of a particular age, height, weight, and sex. So looking up those reference values, you can see if a patient's vital capacity is less than 80% of that reference value. If it was, that would suggest a restrictive disorder. If the vital capacity was totally normal, then what you could do is assess the FEV1 and vital capacity ratio. So it looks something like this. If you have the patient breathe as much as they possibly can and then breathe out forcefully as hard as they can and as long as they can, if you see how much of that air they breathed out in 1 second and you compare it to the total amount of air that they breathed out, it should be greater than 70%. Normally it's about 80%. Okay, in other words, if you breathe out forcefully, you should be able to get rid of 80% of your air within a second. And if you're getting out less than 80% of your air, if you're getting out less than 70% of your air in a second, then there's a problem. There's something that's keeping that air from getting out as it should. It could be asthma, it could be inflammation. There's something going on with the airways. They're obstructed. It's increasing resistance. It's taking more effort, more time for the air to get out. It doesn't get out as easily. And so within 1 second, you can't get out as much. Now, you would still be able to get out all of the air. It just takes longer. Okay, it would take maybe 2 or 3 seconds, 3 or 4 or 5 seconds to get rid of it all instead of 2 or 3 seconds to get rid of it all. So that is a helpful metric of the ratio. And you might think about in a restrictive disease, you would probably actually expect that the FEV1 would be mostly normal. You would still be able to get out the same amount of air in a second compared to a normal state, but because the vital capacity is less, you're dividing that same number by a lesser number, so that would actually make this ratio increase. So another way that you can assess this, one is just by looking at the reference values for vital capacity, but also if you were looking at this ratio, you would expect this to be higher than 80%. Okay, meaning you're able to get rid of more than you should have actually in a second of the fraction of your vital capacity. Okay, now a quick note here about the difference between what's known as the respiratory minute volume and alveolar respiration. These are two metrics that are often discussed when we're talking about pulmonary function. The respiratory minute volume is just essentially how much air can you get into and out of your lungs, how much air do you move into and out of your lungs in 1 minute. And you would calculate it by taking the respiratory rate, how many times somebody breathes in a minute, by the average amount of air they breathe every time they breathe, which is the tidal volume. So if you take the respiratory rate, you multiply it by the average tidal volume, you'll get the respiratory minute volume. This is different than, and we call that the VE, respiratory minute volume. This will be a different metric than what's known as the alveolar ventilation, which we would call V for ventilation A. And to figure that out, you'd have to know what's known as the anatomic dead space, which would be all the volume occupied by the conducting airways here. You're never going to get that out. And so the alveolar ventilation tells you not only how much air did you move into and out of your lungs, but specifically it gives you more of a metric of how much air did you get into and out of the specifically alveoli. That's probably a more physiologically relevant metric to use because it helps you understand how much air is getting to the actual site where gas exchange is going to occur. And so to make that calculation, you have to just account for the anatomic dead space. You would have to figure out breaths per minute, same as the minute volume. But then you have to also count the tidal volume, same as the minute volume, but subtract from it the anatomic dead space. And you probably couldn't measure that. That would be something you'd have to look up based upon somebody's size, sex, and height. Okay. And if you account for the dead space, then you're left with how much air is specifically making it to the alveoli every time you breathe. And then if you multiply that by breaths per minute, you'll get the alveolar ventilation. Now, how is the respiratory rate and the ventilation controlled? Neurologically, there's some centers in the pons and the medulla. There's some various bundles of neurons here in the medulla that are sort of in the ventral side here. And what they do is they are the ones that are starting it. They're starting the rhythms. They're starting the action potential at a certain rate, and that's going to set the basal rhythm of your breathing. And what they do is they send connections up to these two spots, which are called the ventral respiratory group and the dorsal respiratory group. And these sit right between their upper and the higher portions of the medulla oblongata, which would be this part here, almost close to the pons, which would be this part here. And when they do send those connections up, then depending on where they go, if they go to the front or to the back, they'll have different consequences. The dorsal group, the one in the back, this stimulates your diaphragm and your external intercostals. So here's your diaphragm. There's going to be, what they do is they have these interneurons that connect with the motor neurons that are going down to specifically the muscles. And so if these get activated, they can catch those motor neurons that are going down to the muscles and turn them on. And one big nerve that would do this is called the phrenic nerve. This is the one that goes down to your diaphragm, and it would cause it to contract. So in other words, these stimulate your normal respiratory muscles for normal breathing. So every time you breathe, it all starts with these collections of neurons in your medulla. They will give the dorsal respiratory group a little jolt of electricity, and then that will then make it that will catch then the nerves that pass down to those muscles, and they'll start to contract those muscles, and you will breathe. Now, these centers, in addition to receiving inputs from these collections of neurons, they also receive feedback information from stretch receptors. There are stretch receptors in the muscles here and in the tissues of the thorax that when they get stretched, they are the signal to cut off the stimulation. If that wasn't the case, you would not have a normal breathing. Every time you wouldn't have a normal breathing depth. You would be over breathing each time you breathe. So there's like a set amount of stretch that your lungs will accomplish before they trigger the stretch receptors and then send a kill switch basically to the innervation, and then that will cause your muscles to relax. And this is a great thing because you don't have to consciously think about when you're going through your day to life how much you're filling your lungs. The stretch reflex does that automatically for you. Your lungs will only extend to a certain amount before they're stretched to the degree that then shuts off the signal that innervated them in the first place, the signal that was coming from the dorsal group. Okay, on the flip side then, you have the ventral group, and this is also going to stimulate muscles of inspiration, but specifically these are going to be a different set of muscles. These would be the intercostal muscles, and then some of the accessory muscles. So the diaphragm and the external intercostal, they're considered more primary muscles of respiration, but there's a whole host of other muscles that can aid in respiration because they help you lift and expand the thoracic cage even to a greater extent than that which is accomplished by the external intercostal muscles. So some examples of accessory muscles you would have, like there's a sternocleidomastoid muscle in your neck. So if you're breathing really heavily, you might even feel your neck sort of getting into the rhythm. You have the sternocleidomastoid on the mastoid processes of your temporal bone, and then it comes down and grabs onto the clavicle and the sternum. So it can help to lift up your sternum a little bit. You have the serratus anterior muscles, which can help pull back the ribs a little bit and pull the ribs up. There's a group called the scalenes, which are in your neck as well, and they can help to lift your chest up. So if some additional force is required, because there's some very forced breathing, then the DRG can recruit the VRG, and then we can send those signals down also by catching some of the nerves that go to those, normally go to those muscles, and that will cause greater expansion of the thoracic cavity. So normally this wouldn't be recruited, but if there's some more vigorous breathing required, then it is recruited. Well, both of these centers, by way of the dorsal group here, both of the dorsal group is regulated further by some centers in the pons. And there is the apneustic center. This controls the depth of inspiration, and then the pneumotaxic center controls the relaxation. So the role of these is somewhat unclear, but all that to say, there are some higher centers in the pons, which have some important effect in causing this whole reflex to happen. If these centers are ablated or there's something wrong with these centers, at least in some of the other animal models that have been shown, it actually really severely impairs the breathing reflex. So they're important in some respect, not fully understood exactly what they all do. But at the end of the day, what you have to know is there are center in the pons and the medulla that are very important in setting your breathing rate. Now, these centers in the pons specifically, they're actually under the influence of chemoreceptors. So this is where you get some of the feedback regulation, the physiological feedback regulation. Chemoreceptors are found in a variety of places, and they're assessing the chemistry of your body. And you can tell a lot about if somebody is hypoxic or not by the chemistry of the fluids in the body. For example, there are central chemoreceptors that are in your brain, mostly in the medulla and probably in the pons as well. There are also peripheral chemoreceptors, not in the brain, but in two important parts here, the arch of the aorta as well as the carotid artery. There are these little, now this isn't to be confused with the sinus where the baroreceptors are found. These are actually called the bodies, carotid bodies, which is like a collection of nervous tissue that is in close association with the sinus of the carotid artery, and then also wrapping around the aortic arch. And the peripheral chemoreceptors, they're detecting more of the blood chemistry, so they're detecting the amount of oxygen and CO2 inside of the blood. The central chemoreceptors, they're detecting more specifically the acidity, which would be the accumulation of hydrogen ions. If there is accumulation of hydrogen ions, this is a signal that the body is acidic, or going through acidosis, which would be a signal that there is a lack of respiration, or maybe I should say ventilation, that the body is not being ventilated properly, and only generally under conditions where the body is not being ventilated will there be acid that accumulates. Generally, you get rid of CO2, which is going to pull the acid out of your blood. We'll see that in a minute. And if there's an accumulation of hydrogen ions, it tells the body that there's a lack of ventilation, and that would cause these centers to kick in here to help get more depth of inspiration. On the flip side, if there was very little pH, that might mean that the body's working too hard to breathe, which is never really a bad thing, other than the fact that it's just causing an unnecessary amount of energy expenditure. It's a really bad thing to not be breathing enough. It's not so bad of a thing to be over breathing, other than that it just wastes energy. Okay, now in the book there is a table that shows all sorts of centers and things that affect ventilation, but you don't have to know it to this extent. So for my purposes, I'm really just concerned that you know that you have the normal breathing rate set by this dorsal group. If you need some extra help, you can get the ventral group involved, and the dorsal group is going to be sending signals, catching the motor neurons going down specifically to the diaphragm and the intercostal muscles, so that'd be the phrenic nerve going to the diaphragm, and then that's under control of some of the centers in the pons. Okay, if you know it to that level, it's all good. Okay, you should know that also there's some feedback here of the chemoreceptors and understand why the chemoreceptors are significant, what it is that they're assessing, and how that tells the body something about the conditions of ventilation. Okay, let's talk then what happens once we get air into and out of the lungs. Where does it go? What happens to it? This is what's known as respiration. Respiration is just a general word that means the exchange of gases, and it can happen on a more macroscopic level, or it can happen on a more microscopic level. Specifically, you have two forms. You have external respiration in the respiratory system, and you have internal respiration. And external respiration is what's happening between the lungs and the blood, and internal respiration is what's happening between the blood and the tissues of your body. And the story, before we can get into the story, we have to have a little background information here on what's known as Dalton's law. Dalton's law says something like this: if you have gas in the air, there will be what we call partial pressures based upon how much of the air they compose. Okay, so for example, in the book we have this figure showing that oxygen and nitrogen, let's say that this is atmospheric air, which is very close to what it would be. Most of the atmosphere is oxygen and nitrogen. Well, if you looked just at the oxygen and nitrogen of the air, it composes a total pressure of 752 millimeters of mercury. So that would be like if I took a pressure gauge and I measured the pressure that the atmospheric air is exerting right now, I would get something close to this. But the reason I get that is because there are individual gases in that mixture which each have their own pressure to them, and if you add them together, the pressures summate. They add to one another to create the full pressure. So that's all Dalton's law is saying. It's saying that if you were to distill out the atmospheric air into separate gases, they would have their own pressures associated to them, and if you added those pressures together, it would come back to the pressure of the mixture. Here is then how it truly shakes out in the atmosphere. You have nitrogen, much of the total composition, and so the total composition of air is 760 millimeters of mercury. Well, if that's the total pressure of the atmospheric air and nitrogen is 78.6% of it, then the pressure specifically of just the nitrogen itself, how much of the total pressure it contributes, if you were to be able to pull out all the nitrogen gas and just isolate it in the same volume, the same container, it would not exert a pressure of 760, it would only exert a pressure of 597 because it's 78% of the total. Okay, and looking at some of these values, we don't really pay attention to any of these other values here except carbon dioxide and oxygen. Those are the predominant gases we're concerned about. And just keep in mind then that there is almost next to nothing carbon dioxide in the atmosphere. And then there's about 160 millimeters of mercury of partial pressure of oxygen in the atmosphere. And these then are going to be the numbers that determine how gas gets into and out of the blood. This is determined by another law, which is known as Henry's law, which basically says Whether a gas is going to go into a solution or not, so the case here being whether or not oxygen is actually going to get into your blood or not. Your blood is a liquid. So whether or not oxygen is going to get into your blood or not depends on its partial pressure. If you have a higher partial pressure, it's more likely that the gas would go in. So, for example, let me back up, and it also depends on its solubility. So, for example, oxygen is much more soluble to your blood than nitrogen. If nitrogen, which has a really big partial pressure, so there's a strong tendency there for nitrogen to want to go into your blood, but because it's not soluble in your blood, it rarely goes into your blood. That's not the case with oxygen. Oxygen is more soluble. It likes to be in your blood, and it likes to be in your blood specifically because there's a really great molecule to which it binds, which we'll talk about in a second. So you don't get a lot of nitrogen going into your blood because even though it has a strong partial pressure to push it into your blood, it doesn't have the solubility. Oxygen has a pretty strong partial pressure and it's highly soluble, so you get a lot of oxygen going from the air in the atmosphere and traveling then and residing in your blood. So that's what Henry's law states. Okay, so here's the story then. External versus internal respiration. This is a great figure. You're going to want to know this figure, and you're going to want to know some of the partial pressures here that have been illustrated. Okay, remember that we have a partial pressure of oxygen about 160 millimeters of mercury. That comes off of this table right here. We had about 160 in the atmosphere. Well, you can see by the time air gets down to the level of alveolus, that's dropped, meaning we've lost some of the proportion of molecules that are oxygen. And this is due partially because they are diluting with carbon dioxide, and you're not getting, the air is mixing with expired air when it gets to the level of the alveolus. You have inspired air coming in and expired air always going out. So there's quite a bit of mixing happening. All in all, though, because there's such a huge reservoir of air in the atmosphere, and you're constantly breathing, even though the expired air and the inspired air are mixing, you end up with a net gain at most all times. If you were to assess the alveoli, they would have a partial pressure of about 100, which is pretty good. That's quite a bit of oxygen that is sticking around in the alveoli. And if you were to look at the CO2, they're always taking in CO2 from the blood. So there would be, if you measured the air inside the alveolus, the amount of the fraction of it that is going to be CO2 would be about 40. That's way higher than standard atmospheric air, because in atmospheric air you only had about a 0.3 partial pressure. Of the total 760, it was only 0.3. Well, in the level of an alveoli, out of the total 760, now you have closer to 40. Okay, so there's a greater percentage of the air in your alveolus that is occupied by carbon dioxide molecules than, and that's probably at the expense of nitrogen molecules. So there's probably less nitrogen, a little less oxygen, and more carbon dioxide in your alveoli. All right, so that's the state, 140. Now, this is talking about external respiration, which is the exchange of gases that is happening between the alveolus and the capillaries of blood that pass through. Remember, we said that this happens really quick. The blood passes through, and that's the only opportunity it has right here at the respiratory membrane, only about a micron thick, or a tenth of a micron thick. This is the only opportunity that there is for gas to exchange. The incoming blood that's just been from the body, it typically has this condition. The PO2 is less, it's only about 40, and the PCO2 is quite high, it's actually 45. And because of the conditions in the alveolus, where we have a percentage of gas that is such that makes the partial pressure of CO2 only 40 and the partial pressure of oxygen 100, now we have concentration gradients. We have, on the one hand, a gradient that favors the diffusion of oxygen into the incoming blood. You have a high pressure here of 100 and a low pressure here of 40. Gas always wants to go from high to low, just the same as anything else. And so there's a really favorable gradient there, or there's a gradient there that greatly favors the influx of oxygen into the blood. On the flip side, you have a partial pressure of CO2 of about 45 millimeters of mercury, and it's only 40 in the alveolus. So this actually has a concentration gradient going this way. And so then naturally, as the blood passes through, you have onboarding of oxygen and you have offloading of CO2 as the gases flow down their concentration gradients. This will then equilibrate with the alveolus. It's not the case that the alveolus equilibrates with the incoming blood. It is rather the case that the blood equilibrates with the conditions of the alveolus because there's a much greater reservoir of gas coming in and out of the alveolus. Its conditions maintain relative constancy here. So as the blood passes through, it equilibrates such that then the blood that's leaving has now taken on the properties and the composition of the air inside the alveolus. You can see this is exactly the same now. The PO2 leaving is 100. That matches what the alveolus was. The PCO2 of the blood is 40. That matches what the CO2 was in the alveolus. So now you've completed external respiration, and the blood has loaded up some oxygen. It's gotten rid of some CO2. And now that blood's going to come back through the pulmonary veins, back to the heart, through the left side of the heart, and now out to the body. And then it eventually goes through some arteries, which get smaller and smaller. It finally makes its way to the arterioles, and now it's into the capillary bed. So here's showing a snapshot of what's known as internal respiration. And this is the exchange of gases happening between the incoming blood from a capillary bed and the tissues that surround and are nearby the capillary. Okay, so here you can see we are pretty consistent with the conditions that the blood picked up as it went across the alveolus. Here it was 140, but now here it's 95 and 40. So it's almost the same except for this. We've lost a little bit of oxygen, and that's just because the vessels aren't totally impermeable. There will be some oxygen that slips out. So it's likely by the time you get from the lungs all the way to the heart and then out the arteries and now finally to the capillary beds, you've maybe lost a little bit of oxygen along the way, but not much. But there is a slight decrease here in the amount of oxygen. Well, similarly then, there's the tissues of your body are much bigger reservoir than just the small fraction of blood passing through a small capillary. So similarly before, the blood equilibrates with the external conditions around it, and it takes on those conditions, and so you have oxygen diffusing down. The tissues, the interstitial fluids surrounding the cells in your body usually have a PO2 only about 40. And then because the cells are making CO2 as they undergo their energy making processes, that's creating some CO2 and that's accumulating, so you have a little bit of a higher CO2 at the level of the tissue, the cells. And so naturally you follow the gradients. You have high oxygen here, low oxygen here, so oxygen is going to want to diffuse into the cells. Similarly, you have a higher CO2 right here in the interstitial fluid, the fluid surrounding the cells, than you do with the incoming blood. So now you have diffusion of CO2 into the blood. And by the time the blood passes through the capillary bed, its conditions are going to be matching that of the interstitial fluid surrounding the cells. And then this goes and travels all the way back through the heart and then back to the lungs, and you can see that here we are back at the start. The conditions of the blood leaving the capillary bed are identical to the conditions of blood entering and crossing the alveolus. And then the whole process happens again. Okay, so in summary, you have blood with this chemistry coming into the alveoli, oxygen coming on, CO2 leaving, then that blood passing on, going to the body, losing a little oxygen, but then delivering the rest of the oxygen, taking on some CO2, and then the story just repeats. Now, the way that gas is transported in the blood is probably, maybe we'll stop here and we'll save that for another final lecture.